Chapter 26, Soft Tissue Injuries, Part 2 of 3. So now that we have talked about how, why, signs and symptoms, and when we're going to find it, let's look at how we're going to treat these injuries. When it comes to the small contusions, those small bumps and bruises, we're probably not going to do anything. You might give a little ice, but for the most part, there's nothing special that we're going to do. You do want to, of course, note their presence. When we have more extensive injuries, whether they're closed or open, we obviously increase the risk that our patient's going to go into shock and that they need additional medical care. So no matter how minor, that small contusion may be just the beginning of a bigger issue that's arising. We always want to monitor the condition of our patient and their wounds. Most of our closed injuries are going to be treated using RICES. And RICES can be used at home too. That's rest, ice, compression, elevation, and if necessary, splinting. If your patient has determined that they want to go to the hospital, then you definitely want to make sure that you position them appropriately to be able to elevate above the heart, and you provide rotating ice. Now, ice shouldn't be the full time. Ice should be 20 minutes on, 20 minutes off. But for the most part, your goal is just transport and monitor for the signs and symptoms of shock. So again, no matter how minor it may appear, it is always possible that this can become more significant. So you should always be monitoring your patient for anything that can clue you in to the beginning stages of shock. So an increased heart rate, increased respiratory rate, the decrease in blood pressure, and then of course, the longer it goes, you've got changes in mental status, significant issues and changes in the skin, to show you that the perfusion has significantly decreased. When we look at open injuries, obviously there's going to be more that needs to be done. So, you want to, because it's an open injury, there will be bleeding, and you have a patient who is going to expose you potentially to bodily fluids, so PPE is important. The first treatment as you arrive may be you telling your partner to provide direct pressure to a significant life-threatening bleed. And then we're going to look at different types of wound treatments that we do depending on where on the body the injury is. So your chest and abdomen are going to get different types of wound coverings and treatment than your legs and arms. So as we learned last chapter, we control bleeding using 3 steps: direct even pressure and elevation, pressure dressing and or splint, and tourniquets. Obviously, if one stops the bleed, then you don't move on to the next one. So direct pressure, pressure dressing and elevate, direct pressure and elevation, pressure dressing and or splint, and then a tourniquet. When we consider open wounds being a risk for exposure to pathogens, we always have to make sure we're covering the wounds. You're not going to remove material from an open wound, especially because of the fact that what you remove might actually belong in the body. So you might rinse it and apply a sterile dressing, but you're not going to dig around and debride the wound. You won't, and if it's a large wound, you're not going to rinse it, because of course that could slow clot formation. In most circumstances, the wound is cleaned at the hospital. And then of course you want to consider whether splinting the extremity is going to provide better help with controlling the bleeding. Now, when we look at abdominal wounds, we see obviously a bigger risk here. So the abdomen is covered with a lining, and muscles that are preventing your internal organs from becoming out organs, external organs. So what you've got to look at is the fact that an open abdominal wound can potentially expose internal organs. And remember that those internal organs live in a moist environment. So when we have an abdominal wound with protruding organs, we call it eviscerations. An evisceration, again, is when you have an open abdominal wound and organs are protruding. So like in the picture on the screen, you can see the intestines are coming out the bottom, and probably that's more intestine at the top. And obviously, not only is this a risk, but they can dry out. They can be strangulated. This is much like a hernia. They could lose circulation. So this is a high priority patient. And we treat it slightly differently. With our abdominal wounds, we are going to cover the wound with a sterile gauze, a moist sterile gauze, and we are going to secure it with an occlusive dressing. So an occlusive dressing is a dressing that it's non-permeable. So once I moisten it, and then I secure it as an occlusive dressing, it's not going to allow airflow. It's not going to allow pathogen flow. So it will remain moist. Most of the time, an occlusive dressing is plastic covering. And here it's got to be taped on all 4 sides. So abdominal wounds, and go ahead and write this down, abdominal wounds, occlusive dressing, all 4 sides. And we want to make sure those organs stay moist and warm because that is the environment they live in. And we want to make that environment such while we transport them to the hospital. When we're treating impaled objects, the first thing to remember is that unless the object is impacting the airway in the cheek or the mouth, or unless the object is interfering with CPR, we must not remove the impaled object. So again, if the object is interfering with CPR, or if it is in the mouth or cheek and obstructs the airway, keep the impaled object in place. If the object's very long, you're going to want to shorten it and then secure it. And what we're going to do is we're going to treat it by applying bulky dressing. So putting a bunch of heavy trauma dressings, sterile gauze, that type of stuff around it so that it doesn't move or shift during transport. But do not remove it. If it's long, secure it and then cut it so that your patient can be transported appropriately. If it's a neck injury, we have to remember that this patient is likely to face life-threatening injuries. So neck wounds can cause air embolisms. It can obviously cause significant major bleed from the wound, meaning that the patient may not be getting oxygen to their brain that they need. Like the neck wounds, like the abdominal wounds, your neck wounds are going to be treated with an occlusive dressing. Again, we don't want air coming in. We don't want there to be a risk of an air embolism. So an occlusive dressing, once again, is going to prevent airflow to occur in the wound. And that should be how any wound, regardless. So even if the wound is towards the back, we're going to treat it with an occlusive dressing so that there's no risk of an air embolism. We do want to apply manual pressure to control the bleed, but we're not going to do it on both sides of the neck at the same time. Go ahead, picture it, manual pressure, both sides of the neck. Yeah, basically you don't want to choke your person or your patient, and we don't want to apply a tourniquet to these wounds either. The good part is that if they require C-spine immobilization, that C-collar is going to provide that direct pressure to help control that bleed. When we consider small animal bites as our soft tissue injury, we need to recognize that that has a high risk of pathogens entering the body from the animal's mouth. So the wound may require additional care, such as debridement, antibiotics, etc. And debridement means, flushing out, pulling out anything that may have been left in. Antibiotics, a tetanus for the patient, and even potentially surgical repair. You've got to make sure that you really highly recommend getting your patient to the hospital so that they can get additional care. One major concern we have is the spread of rabies from animal bites. So we've got to, again, be very concerned about any animal bite, asking if this was an animal who maybe was behaving weirdly. Was it a wild animal or a pet who hasn't been behaving appropriately? And the treatment, the vaccine for rabies is not fun. So our goal is to get them to the hospital, but to also recognize that that animal, if they're still on scene, could become a danger to you as well. So our goal, of course, is to make sure that we are keeping scene safe, monitoring scene safety as we go. Of course, human bites are also a concern too. So we need to kind of treat this the same, that there is even actually higher risk of there being pathogens that can cause infection and viruses in the human mouth. And if there has been any penetration, any break in the skin, we've got a serious concern, need to flush, cover, and transport this patient to the hospital. So how do we treat human bite wounds and even the small animal bite wounds? We're going to apply a dry sterile dressing. We're going to immobilize or splint the area so that they're not moving it around. Remember, any pathogen that enters the skin through this bite is going to be moved quicker as the heart rate increases. So dry, sterile dressing. So this is a 4x4 or gauze that comes out of a package, secured with tape or with roller gauze, and then transported to the hospital. Burns can range in severity and significance, and they actually account for over 3,400 deaths per year. They are some of the most painful and serious injuries that we'll deal with, especially soft tissue injuries. And if you've ever gotten a sunburn, you know that. By definition, burns occur when the body is exposed to more radiant energy than it can absorb. And burns can occur through a variety of energy sources, including heat, chemicals, and electricity. Radiation as well, though we don't tend to see those as frequently as we do heat, chemical, and electrical burns. While burns can be overwhelming when we see them and they can kind of give us some tunnel vision, we need to make sure that we're conducting a complete assessment of this patient to ensure that no serious injuries are present or no additional injuries are present. And recognize, of course, that children and older patients and those with chronic illness are going to have maybe less severe burns with more severe consequences. So burns, again, are soft tissue injuries that occur when the body is exposed to radiant energy it cannot absorb. So when it is in low levels, we can handle it and our body can absorb it and convert it. Thermal burns, more specific, occur when the skin is exposed to temperatures higher than 111 degrees Fahrenheit. So thermal burns and that energy are, of course, very concerning. The severity severity of the thermal injury is going to be based on temperature. So obviously, the higher the temperature, the more severe the burn. Concentration, is it directed at a specific area or is it the entire body? How much heat energy is possessed and how long they were exposed. The longer the exposure, the more severe the burn. When the heat energy is more significant, we also are faced with the potential that it will be deeper, so it won't be a superficial heat injury. Though most people are able to deal with the severity by removing themselves from the environment. When a person's burned, the skin is destroyed. And so that creates a high risk of infection, hypothermia, hypovolemia, and shock. Remember, this is the skin, and the goal of the skin, the function of the skin is to maintain moisture, to keep out pathogens, and to control temperature. So when the skin goes, especially in large areas that it might be, when it's a burn, you see a significant issue with all of those functions. Burns to the airway are going to increase significant issues. Burns to the airway mean that anywhere in that airway path, your patient may be suffering swelling, damage, destruction of the functions and the structures. And then circumferential burns of the chest can be concerning as well because they are going to constrict the ability of the patient to take a deep breath. When it's a circumferential burn in the extremity, you look at a greater risk of neurovascular damage and even compartment syndrome because, again, it is squeezing the extremity and the nerves and the tissue underneath. We measure burn severity based on a number of factors, including the depth of the burn, the extent of the burn, whether or not the burn is covering critical areas, pre-existing medical conditions, and the patient's age. So each of those can impact whether or not we view this as a serious burn. When we look at the depth of the burn, we are going to look at it in three different categories: superficial, partial thickness, and full thickness. We used to teach first, second, and third degree burns, but now we look at superficial, partial thickness, and full thickness. Superficial burns are, general sunburns. These are the top layer of the skin, and then they often present with red coloring, but no blistering. And it's going to be painful. But it's not just sunburn. If you've ever been to a bonfire and stood too close to the fire for too long, you might have come away with redness in your skin. So again, it's only the top layer will be red and painful, but no blistering. Partial thickness burns involve the epidermis and a small portion of the dermis, and these are burns where we see blistering. Partial thickness burns may not be painful because it might damage the nerve, but more than likely it is going to be severely painful because the nerve is going to be exposed to air as the epidermis and parts of the dermis are destroyed. Again, there will be blistering, and the skin will be kind of a mottled red and white, so it's not going to be completely red, not going to be completely white, kind of a mix of both here and there. And again, it will be very painful with blisters. And then full thickness burns extend through all layers of the skin. It's going to create skin that is very dry and leathery to the touch, maybe even looking charred. If the nerve ending is destroyed, they will have no feeling in the area of the burn. But as you get away from the full thickness burn, you might actually find areas of second and first degree, partial and superficial burns as well. And again, if these burns are near the airway, you've got to be checking for soot in the nasal passages or around the mouth, singed nasal hairs, burns, and blistering around the nose and the mouth. Each of those are going to be a clue that I am facing a patient who may need advanced airway support. So this picture kind of shows you both in a skin and then in a real life what each of those burns looks like. So you've got the girl who didn't put on enough suntan lotion. She's got her superficial first degree sunburn there, only hitting the epidermis. Then you've got the middle picture. You see the blistering and you see that mottled skin, so you can see where the red ends and the white begins. That is your partial thickness. And then the third picture is a full thickness. And here you see areas that have third degree or full thickness, but you also are going to see some areas with second and even first degree burns as well. We are going to look at the extent of burns using one of two methods. The first being the rule of palm. So the rule of palm says that your patient's palm represents 1% of their body surface area. So as you look at the injured area, you would consider how many palms it would take to cover it. Or the rule of nines. The rule of nines recognizes that each body area, each section, represents approximately 9% of the patient. So, each body area represents that 9%. So when you look at how much is burned, you're going to be doing math. And we have to, of course, recognize that the proportions of the child and the infant are going to be different than the proportions of the adult. So the rule of palm tends to be a little easier because you don't have to remember different proportions for different patients. But the rule of nines tends to be more specific. And when you're doing your calculation, you only want to include partial and full thickness burn areas. So this is a picture showing you the different breakdown of the percentage for sections. So the adult, the legs are 18, the front 18, back 18, the arms, front 9, back 9, the abdomen and chest are 18, the head is 9, the back is 18, and the groin represents 1%. So you can see the difference there. Of course, babies, their heads are much bigger, so the head is going to represent 18% completely. The legs are smaller, they're going to represent differently. Across the three different patient sizes, arms are going to be the same, and chest, abdomen, and back are going to be the same as well. Remember that it's important to classify the patient's burn based on source, depth, and severity. We're looking, superficial, partial, and full thickness burns, thermal burns, electrical burns, that type of stuff, especially as you notify the hospital so that they can prepare for the patient. So now that you know what to expect, let's talk about our assessment of these patients. And again, it's really not that different, though it is important that you are paying attention to scene safety, especially if the burn is something, the cause of the burn is something that they may still be around or that you may have to be exposed to. When you're taking tests regarding EMT, especially those of you who are on the fire side, if the question is about a patient who is burned or a patient who is visible but there's a fire, you don't go in. You wait for appropriate assistance to come that can get the patient safely for you. We need to remove our patient from the setting. We need to determine the type of burn, the source of the burn, and where the burn exists in order to better prepare and enter the scene. Also, consider how many patients there are as you're looking at mechanism of injury. If it was an explosion, if it was a thermal burn, were there other people that were in the room? And so you've got multiple patients. Do you need additional assistance? And is there a possibility that the patient has other injuries that you need to be concerned about? For example, is the patient, did they have a break? So they've broken a bone and they have the burn, or the soft tissue injury and the burn and there's a laceration. You need to treat everything, obviously the most severe cases and issues first. Once you've got that general assessment of the scene and the mechanism of injury, we're going to move on to that general impression. Checking our responsiveness using AVPU. Also looking at the injuries during your rapid exam and considering whether or not they could potentially have been caused during abuse. So is it a child and they've got circumferential burns in their lower extremities as though someone put them in a hot tub of water? Or is it like cigarette burns that are all over their body that you're treating? Look for clues that may help you determine the severity of the injuries this patient is facing. Once you've done that, we move on to airway. Is it open? Looking for signs that they have burned their airway. If they have taken in hot gases or vapors, you may see singed facial hair or soot around the nose and the mouth. Consider whether or not that airway needs to be protected with an airway adjunct. Are they making noisy respirations? Do they have a lot of secretions? If you guys, those of you who are firefighters, even if you're on air, when you go into rehab, you're still potentially going to be breathing in the dirty air. If you've ever taken that shower a day later, a couple hours later, and had, kind of dirty snot, you are taking in the vapors and the gases associated with that fire. Check for airway, again, patent, but are they breathing? Is the breathing quality to support life? Do you need to put them on 10 liters or 12 liters of non-rebreather? While you listen to the lung sounds, do they sound like good respiratory effort is happening? And also look at that chest wall for DCAP BTLS. This is all still part of your ABCs. With breathing taken care of, we still move on to circulation. Pulse, quality, rate, rhythm, skin color, temperature, and condition, any significant bleeding. You know how to control bleeding, now you're controlling it if it's a life threat. Direct pressure and elevation, pressure bandage and splint if necessary, and then a tourniquet if bleeding still isn't controlled. And treat for shock, because burns screw up the integrity of the skin. You see an increase of loss of volume and loss of heat. So shock is going to be a significant issue that you need to be aware of. And make that transport decision. Any significant areas of burns in major body areas, circumferential in the chest, airway burns, all of that, those are going to be patients who need high priority transport, external bleeding associated with it. Those are the patients we want to get in the back of the truck. And if ALS isn't on scene, we're either going to get them there quickly or we are going to meet them en route. When we're talking and investigating the chief complaint, we need to look for other issues, especially if the burns are partial thickness and significantly painful. That may mask some of the pain associated with other injuries. We're looking for that pain, redness, swelling, blisters, charring, all of those things that we expect to see in the skin of a burned patient. We need to be alert for other symptoms. If the burn is the result of an explosion, so a propane tank, a gas grill, that type of stuff, maybe there are other injuries and blast injuries you need to be concerned with. Let's start talking about the type of burn, and remember that the emergency care of the type of burn, it regardless always starts with cooling. We need to stop the burning process. Once the burning process is stopped with, you may flush it to cool it off. Then we need to apply a dressing, so a dry, sterile dressing on top of the wounded area, and then again continue to treat for shock at this point. Get that sample. Do they recognize that maybe they're having some problems swallowing, breathing, significant pain? How long? How was the burn? Did they remove themselves? How long were they exposed to the source of the burn? Those types of questions, along with the standard sample, signs, symptoms, allergies, medications, past pertinent, and last oral intake, and what were they doing before the events. We're going to do a physical examination of the entire body for this patient, even if they're just complaining of a small burn in one area. Again, the pain from the burn could be masking other issues. We are going head to toe with DCAP BTLS. And guys, it's going to hurt. Now, don't pop any blisters, but as you are assessing that head to toe, it's allowing us to make that estimate of the body surface area that has been burned, looking at either the rule of nines or the rule of palms to determine the burned area. Appropriately package the patient. If they're not already in the back of the truck, and you're not already transporting, now you've got to consider, I've backboarded them, they're on the stretcher, that type of stuff as well. We're going to especially monitor that airway some more, recheck lung sounds, just to make sure that any issues associated with respiratory burns aren't just now showing up. And reassessment is going to be the same. We are going to reassess our primary assessment, looking at the airway, the breathing, the circulation. We are going to reassess the chief complaint in the specific area, make sure interventions are still working. Does the wound still feel warm? Have we fully stopped the burning process? How is the oxygen? Do they need more? Do we need to bag them now? Providing appropriate support in the circulation system as well. Our reassessment hasn't changed in what we do, it's just maybe the focus is different based on the injuries. And then of course we're going to consider whether oxygen and whether the patient has been treated appropriately for signs of shock. We've got to transport as quickly as possible, even if it's a lower percentage of the body surface that's been burned. Again, because the skin is responsible for temperature control, we have to recognize that this is a problem. And when we communicate and develop our documentation for the hospital, we need to provide them the amount of data we have on this burn, where, how much, how, what you've done, and how the person has responded. And if it's a significant enough burn, the best location to transport this patient is MCV, because that is our burn facility.